Hello, my name is Dr. Dinesh Chhetri. I'm a professor and vice chair of the UCLA Department of Head and Neck Surgery, and I'm also a laryngologist, a doctor who specializes in voice, airway, and swallowing disorders. Today I'll be talking about benign vocal fold lesions, principles of management. So today I'll focus on common benign lesions of the larynx. Common lesions of the larynx include nodules, polyps, cysts, pseudocysts, granulomas, rhynchizedema, also known as polypoid chorditis, and papillomas. There are other growths of the larynx that are uncommon, such as webs, scars, varices, infections, and growths related to amyloidosis, sarcoidosis, and other systemic disorders. I will not cover that today. So when we're thinking about treating vocal fold lesions, preservation of voice is critical. And so in order to treat this effectively, we have to think about two important concepts. One is laryngeal biomechanics. How does the larynx produce the voice? The second is the specialized histology of the vocal folds, the vibratory layer of the vocal folds. So here you have a picture of the larynx. This is an endoscopic view, something we would see in our clinic. And here you can see vocal folds, a right vocal fold and a left vocal fold. And this view is where it's showing the superior surface, the top surface of the vocal folds. There's also a surface of the vocal folds we can't quite see. It is just on the inside of the superior surface, and we call that the medial surface. And that's a very important concept, as I will discuss in the next slide. So if you were to take that vocal fold and just to take a slice of it, what you would see is there is a section on the inside surface. This is called a medial surface. And then a surface that you actually see, that we see from the top, the superior surface. This medial surface is actually the vibratory edge. And this is not the edge we see during clinical exams, during office laryngeal endoscopy. But because this is the vibratory edge, lesions that grow on the surface create a lot of problems with voice. Whereas the superior surface is the surface that gets exposed to chemicals, for example, smoking, and we can have growths there, but lesions on that surface, they don't affect the voice as much. So there's a very important concept related to how these lesions develop in the vocal folds, and it's called phonotrauma. Phonotrauma means trauma related to voice use. So if you look at that slice I showed you earlier where the vocal fold has the medial edge and the superior edge. And this is actually an experiment done at UCLA looking at the amplitude of vibration of the vocal fold edge. And you see that as you go higher and higher on the medial surface, the amplitude of vibration gets larger and larger. So what that means is that that's the area that's seeing the most amount of trauma during vocal fold vibration. So most of the phonotraumatic lesions, they occur on the superior and medial surface of the vocal fold. And here is an example of what happens. So this is an example of nodules, which is a phonotraumatic lesion. They are usually bilateral, they're fairly symmetric. And this causes some stiffness of the vocal folds and reduces the vocal fold pliability. These do resolve completely or nearly completely with voice therapy. Another really important concept to understand when treating vocal fold lesions is the biomechanical anatomy of the vocal fold vibration. This was a model presented by Dr. Hirano in 1974 called the body cover layer model. And what this means is that the vocal fold can be divided biomechanically into two parts. One is called the body layer, which is composed of the thyroidnoid and the vocalis muscle, which is right here. And the second part is called the cover layer, which consists of the epithelium and the lamina propria layer. The stiffness of the cover layer is the most important determinant of voice production and the voice that comes out of the larynx. There is also a normal stiffness gradient that goes from inferiorly to superiorly along that medial surface. Okay? And then scars and growths on the vocal fold, they stiffen the cover layer, affecting the voice. And I'd like to emphasize how specialized this vocal fold layer is and how small it is. So if you look at this histologic section of the vocal fold, you'll see that it consists of three parts. The epithelium, which is about 0.1 millimeter thick. That's about 10 cells thick. The lamina propria layer is about 1 to 1.5 millimeters thick, and the muscle layer is about 6 millimeters thick. Here you can see a picture that I've blown up of a biopsy forceps that we use when we do surgery on the larynx. The typical biopsy forceps is 1 millimeter in diameter. If you look at the size of the biopsy forceps and the size or the thickness of the lamina propria layer, you can see that doesn't take much to remove a significant portion of the lamina propria layer. This layer has very specialized extracellular matrix proteins. These consist of collagen, elastin, hyaluronic acid, decorin, fibromodulin, and fibronectin. And the importance of this is that they're all arranged in very specific proportions and orientations. And we don't really have a way to replace this layer. What is the function of the lamina propria layer? Well, one, it allows mucosal cover layer to vibrate freely from the underlying vocalis muscle. It allows the vocal ligament to lengthen for the larynx to achieve the dynamic vocal range without overly increasing the mucosal stiffness. And the goal, therefore, in surgery is to preserve the cover layer, which consists of the lamina propria and the epithelium layers. So one of the techniques we use in surgery is to expand that 1 to 1.5 millimeter lamina propria layer by a lot by injecting some fluid into the vocal fold lamina propria layer. So here you saw me injecting some lidocaine with epinephrine and expanding this thin vocal fold into a much thicker vocal fold. So I have more room to play when we go in and try to remove the lesions. So I'll next go through some operative principles of microlaryngeal phonosurgery. What is phonosurgery? Phonosurgery is any surgical procedure that maintains, restores, or enhances human voice by correcting the defects in the laryngeal voice production. So these are the principles we follow in operations. Number one, we want to save the lamina propria layer, the cover layer. Second, we want to leave a straight medial vocal fold edge because that improves the contact between the vocal folds and it decreases the glottal gap. The less gap there is between the vocal folds, the stronger and clearer the sound will be. We want to remove any adynamic or stiff epithelial layer. This improves the pliability and the periodic vibration of the larynx. And one thing to remember is that if we anticipate that the voice will be worsened after removing the lesion, particularly if it's a benign lesion, we don't have to remove everything. We also have to remember that excisions on that medial surface can worsen the voice, whereas excisions of lesions on the superior surface, they're less likely to affect the voice. So another important technique to discuss is microflap surgery to preserve voice. So the goal again is to remove the pathologic growth. You can see a vocal fold here with a lesion on the medial surface. We want to remove this lesion while preserving lamina propria layer and improving vocal function. So how do we do that? The microflap technique involves making an incision right on the vocal fold, right next to it or right on top of it. We excise the lesion, and then we preserve the normal tissue, especially the cover layer tissue, and then we just drape the tissue back so that the lesion is removed, all the normal tissue is left behind. Here are some examples of lesions that are treated by microflap surgery. Over on the left, you see a pseudocyst, which has been removed using microflap technique. And when we are done, we are left with a nice straight edge, which then heals with time. In the middle, this is a lesion that was a subepithelial mass, meaning there was a little growth underneath the epithelium, as you can see over here. And again, it's been treated with microflap surgery. And on the very right, we have a vocal fold cyst, which is a small mass, which is under the cover layer, under the mucosa. And again, we excise that by making an incision right on top of it, just removing the mass and allowing everything else to drape over. So next I'm going to go over a few of the common vocal fold growths that we see in our practice. I've already shown you vocal fold nodules earlier, and I've mentioned that the etiology or the cause of vocal fold nodules is phonotrauma. What happens is because of the phonotrauma, there is hypertrophy or a growth, overgrowth of the mucosa that covers the vocal fold. It is located right in the middle of the membranous vocal fold, which is where the highest amplitude or excursion of vibration is. It's usually bilateral, as you can see in these pictures. And this tends to affect women more than men in adults and boys more than girls in kids. And the treatment generally is with voice therapy, and only occasionally we need to do surgery. What about vocal fold polyps? So here you can see on the right there is a vocal fold growth on one side of the vocal fold. So polyps tend to be typically unilateral. They are usually translucent compared to nodules. They can be pedunculated, meaning that they are on a little stalk. And there are many types. So there are exophytic type, translucent, hemorrhagic, and mixed. How should they be treated? Should they be treated surgically or with voice therapy? So a study was done to show that the best responders to voice therapy for polyps were typically translucent polyps, especially if they were associated with muscular tension dysphonia, and especially if the vocal fold contact was still very good. But at least 50% of polyps will ultimately require surgery to treat them. Vocal fold cysts are unilateral or bilateral. On the right, you can see a picture of a cyst that's just under that epithelial layer in the lamina propria space. Cysts of the vocal folds can be either subepithelial, meaning that they are superficial and located within that lamina propria layer, sometimes adherent to the epithelium itself, or they can be a little bit deeper, adherent to the vocal ligament. Typically, they have significant effect in voice because they tent up the lamina propria layer, they tent up the mucosa of the vocal fold, and they affect the pliability significantly. So these typically do not resolve with voice therapy, and we treat them with surgery. So often I'm asked, where did the cyst come from? And it's actually not very clear what causes these cysts to grow. However, we do think that there is some phonotrauma involved, particularly because they are almost always present in the middle of the vocal fold, where you would see most of the trauma to the vocal folds. So we think that maybe it's due to some type of shearing injury to the vocal fold. They can be generally unilateral. They're typically unilateral, but sometimes we see a little bit of a reactive trauma to the other vocal fold. We call it a reactive nodule formation. So here on the lower one, you can see again a cyst, and there's actually some irregularity of the vocal fold on the opposite side due to the contact with the cyst side. And as I mentioned earlier, compared to nodules and polyps, voice can be much worse with cysts because of the tenting effect on the mucosa as the cyst grows. The treatment for cyst is again microflap surgery. We make a small microflap, a small cut right on the vocal fold, right overlying the cyst. And then we perform blunt dissection around the cyst. Have to be very careful not to pop the cyst, because if the cyst pops, there is a small chance of recurrence. However, if the cyst does pop, we can go ahead and remove all the lining of the epithelium. The recurrence rate should be less than 1 to 2%. Post-operatively, after surgery, there should be absolute voice rest for 3 to 5 days minimum. So next I'm going to talk about pseudocyst. So as you can see on this picture, there is a blister-like lesion growing on the right vocal fold, and this is typically what a pseudocyst looks like. And what it means is that it may look like a cyst, but underneath you actually do not have a growth with a capsule. This type of lesion is typically associated with glottal incompetence, and that means that somehow there is either a weakness of the vocal fold, or there is atrophy of the vocal fold, and there is an increased amount of effort being made to produce the sound. And a lesion like this will appear. And because of that etiology, there's also a high likelihood of recurrence after resection of this type of lesion if the underlying glottal incompetence has not been treated. The treatment again is with microflap surgery, as I mentioned before. Here is again a patient with a right-sided vocal fold pseudocyst. It has been excised using the microflap technique, and this is the immediate post-operative outcome. And after a period of healing, it looks quite good. I'm going to talk about a slightly different kind of vocal fold lesion, which we call a vocal fold fibrous mass. This can be unilateral or bilateral. And if you look at this picture over here, it may initially look like a cyst on office endoscopy. However, when we go to the operating room and perform a microflap operation, you do not find an actual cyst, but some amorphous material. Having said that, the treatment is exactly the same. We perform our microflap surgery. We remove just that amorphous material, and we allow the mucosa to drape over the incision line. And again, after a period of voice rest, it does heal very well. Also, typically, these do not respond to voice therapy. So what is Reinke's edema? Earlier, I mentioned that the vocal fold has layers, and it has the layer called the lamina propria space. So it happens to be that this space is expandable. And this area can swell, and it's been typically related to either reflux or smoking or voice abuse. As you can see in these pictures, this is a very mild amount of Reinke's edema. You can clearly see the swelling in this particular patient here. And then again, on this patient, there's a one-sided, very large swelling, almost like a large polyp. And when we perform surgery on them, what we find is some inflammatory material in it. Because the polyp causes increase in mass of the vocal fold and also reduction in tension, patients with Reinke's edema and polypoid chorditis, there is a lowering of the pitch of the voice. The treatment again is with medical management, especially if there is smoking involved. Smoking cessation is key. Treating the reflux and the voice abuse. And occasionally we do need to do surgery to remove a very large growth like this. The treatments can involve many different approaches. First, of course, is the microflap surgery, as I mentioned before, making an incision on the vocal fold, retracting the mucosal flap, suctioning all the extra material within the polyp, and then just trimming the redundant mucosa and putting everything back together. Another option is to take a laser, either a CO2 laser, which we typically use in the operating room, or a KTP laser, which we can use in the office to treat it. And again, all of these techniques can be used, and it's really up to the experience of your treating physician to utilize one of these approaches. This is a picture in the operating room, again showing significant polypoid growth, polypoid chorditis of the vocal folds, and this has been removed using a combination of laser surgery and microexcision using microinstruments. So next I'm going to talk about vocal granulomas, and these are masses that are located at the vocal processes. Now, what are vocal processes? If you look at this picture over here, here is a endoscopic view of the larynx in the office showing vocal folds, a right and a left. And where the vocal fold then attaches over here to a cartilage called the arytenoid cartilage, that area is called the vocal process. And in this particular patient, you can see there's a large mass that's grown at the level of the vocal process. On the top picture, you can see even larger mass with potential ulcerations. So these lesions often present with pain in the larynx. These lesions have two causes. Occasionally, after surgery, for unrelated reasons, patients can present with throat complaints, and when we perform an endoscopy, we will see a growth like this, and we will call it a post-intubation granuloma. Other times, patients present with throat pain, throat symptoms, laryngeal pain, and when we perform an endoscopy, we will see a growth like this, and we'll call it an idiopathic vocal fold granuloma. The causes can be voice overuse, weakness of the vocal cord, poor vocal hygiene, meaning voice overuse. Because of these causes, if we were to just go and remove these in the operating room, they often tend to come back. So we do need to treat the weakness of the vocal cord, the reflux, the voice overuse, perhaps with voice therapy. Occasionally, they are so large that we do need to go and remove them. However, for the granulomas, that is not really affecting the voice very much, and they look very typical, located at that particular place on the larynx. We do not need to biopsy them. So vocal process granulomas can be treated primarily by decreasing vocal trauma. This is done with voice therapy or Botox injection. We also make sure that we treat for reflux using either proton pump inhibitor therapy. Occasionally we have to send patients for testing for laryngopharyngeal reflux or gastroesophageal reflux disease. And then finally, we want to treat the underlying glottic insufficiency, meaning that we want to treat any underlying vocal fold weakness or atrophy. And this can be done with a variety of techniques, including injection augmentation, type 1 thyroplasty, or voice therapy. So next I want to talk about vocal fold papillomas. These are lesions caused by human papillomavirus, and the treatment is surgical. So here you can see, first I'm doing a subepithelial infusion. As I mentioned earlier, this is to save the lamina propria layer. After that, these lesions can be treated with a variety of techniques. I use a microdebrider to remove the papillomas on the medial surface, that inside surface of the vocal fold. And after that has been done, I can take a laser and perform some fine-tuning of removal of the papillomas. Occasionally, we have to give adjunctive therapy, and typically we treat the lesions with cidofovir, which is an antiviral drug. And occasionally, if a patient has significant recurrence of papillomas or the frequency of surgery is very high, then we will treat with Avastin. So the key again for treatment of papillomas is to remove all the disease while leaving normal tissue behind. Because the papillomas do recur, we try not to be too aggressive, and we just want to remove as much of the disease as possible while leaving a nice straight edge and allowing all the vibration to take place. The disease course for papillomas is usually 5 to 6 years, meaning that the disease will die off during that time. So again, the goal is to preserve all the normal tissue so when the disease process has ended, you are still left with a viable larynx. So I've given you a short summary of the benign lesions that we see in our practices. If we can be of any help, please give us a call.